A couple of announcements before we start the second half of this gargantuan session. At the end of the session at 5 p.m., we'd like to take a group photo for all of those who would like to participate. We'll be doing that just in the front of the room here. As this is the inaugural conference, we're certainly learning and adapting on the fly. So we've recognized how important the questions and conversations have been and how we're eager to continue to engage those conversations. So in the spirit of trying to give the maximum amount of time to questions, we're going to start with our speakers and go through both the clinical research partnerships subsession and the capacity building subsession without a break for questions in between. We'll have all 5 of the panelists up at the end of the meeting to hopefully answer as many questions as possible. So I'm going to introduce our next speaker, Peter Kingham, who's coming to us from Memorial Sloan Kettering. Thanks, Peter.
Thank you. It's really great to be here. When I was a resident and did a global surgery rotation, actually, my transcript says I was doing a radiology elective at NYU where I was a resident because it was illegal to leave the country and do such a training endeavor. The statute of limitations is up, so I think I can say it now. But now to have meetings like this, I think means a lot that we're starting to make some progress. So I'm going to talk about, let's see, is the mouse going to advance this or? Oh, this thing, okay, gotcha, thanks. At Sloan Kettering, it's very important that we announce our conflicts of interest. I have 2 nonprofit conflicts of interest, which I don't think will come into play today. I'm going to talk a bit about clinical focus of our partnership and some trials, and then I'll get into the administration, the infrastructure, the funding, the trainees and junior faculty, how we're focused on that, and obstacles. I'm giving this talk really on behalf of ICEC and myself. ICEC Alatishe is a surgeon in Nigeria who's my collaborator in everything I'm going to talk to you about here. ICEC and I met in 2010 when he was on a rotation at Sloan Kettering. I had been doing global surgery work in Sierra Leone for a number of years. He was sort of embarrassed that as a Nigerian, he wasn't working in Sierra Leone, so he joined me there, invited me to Nigeria, and that was really the start of what I'm going to talk to you about now. We're centered mostly in southwest Nigeria. You land in Lagos and you drive 3 hours in any direction to get to our hospitals. Ile-Ife is sort of near the top of that circle. That's ICEC's institution, Obafemi Awolowo University. And that's where we started. This is our index patient. So my first trip visiting ICEC at about 1 o'clock in the morning, he knocked on my door. He said he was going to operate on a 25-year-old who came in with a rectal obstruction from a tumor. And you can see he has a distended abdomen. He was a skinny guy, but his abdomen is distended there with a distended colon and small bowel. So in the middle of the night, we operated to do a diverting colostomy, and there were all these white specks around the abdomen. And I asked ICEC, what are these white specks? Because I've done a fair bit of surgery in sub-Saharan Africa, and there's a lot of different pathology there. There's typhoid perforation, there's TB, there's all these things that we don't see here. And I had seen those, but they didn't look like this. And he sort of laughed that I'm the expert from Sloan Kettering, and I didn't know what a metastasis looked like. But they actually look very different than the metastasis that I see. I'm a surgical oncologist, specialized in hepatobiliary surgery. I operate on a lot of patients with metastasis. But these looked and felt different. So at 1 in the morning, we stood there saying, the patients we saw and the problems we saw seemed to be a bit different. What could we learn from what he was seeing and what I saw? So this one patient led us to start first retrospectively and then prospectively look at cancer patients in southwest Nigeria. So to do this, we started the African Research Group for Oncology, or ARGO. And our theme is really to develop clinically meaningful questions that can impact patient care. And it sounds extremely simple, but it's really the litmus test that we drive all of our ideas through, because it's very easy to go down these rabbit holes that are intellectually or academically interesting but are not going to affect patient care. Now, it may not affect patient care in the next 30 days, but it has to have a realistic mechanism to affect a patient's outcome, or we don't really have the time, money, effort to be able to do it. We started with a pilot grant, actually, from Ted Trimble and the Center for Global Health. And that pilot grant let us start to build some research infrastructure with databases and a biobank. At the same time, at Sloan Kettering, we started to get some interest from our leadership in formalizing a program that Dr. Brennan and I had been doing, just the two of us. And so we started our Global Cancer Disparity Initiatives program in 2013. It's grown now to include surgery, pathology, radiology, epidemiology, anesthesia, medical oncology. We sort of steal Onyinye from Cornell across the street, so she's radiation oncology. And our goal is to improve outcomes for cancer patients in LMIC and really to partner with ARGO. And what we've been able to do is generate prospective data, which is incredibly powerful because you can't do any sort of therapeutic trials if you have no idea what the baseline data are. So this is just an example of what we've been able to learn about colorectal cancer when we started. So these are prospective data from Nigeria compared to a SEER study from the US. The stage 2s and 3s in the US are combined. So 64% of the patients, this was at 5 centers prospectively collected in Nigeria. Everyone who walked in the door with a colorectal cancer diagnosis, we prospectively have about a 15-page questionnaire that we get all of their demographic and treatment data and outcome data on. Every 6 months, our research staff goes back to the patient and updates their clinical status. So 64% stage 4 versus 20% in the US, clearly a big difference. We have survival data now. 6-month survival, 62%, 12-month survival, 48%. These aren't the numbers we talk about, obviously, in the US. The number one thing that I treat is colorectal cancer metastases in the liver. That's the primary surgery that I do. And we talk about curing 20 or 30% of those patients with stage 4 disease. Here, 12-month survival, less than 50%. So clearly, as a starting point, there's really a big role for earlier diagnosis and improving treatments. So when, over a couple of years within ARGO, we've tried to compartmentalize how we wanted to approach even looking at a disease. And we have the same thing for breast cancer. We started with colon cancer and then expanded to breast cancer and now cervical cancer. And we think of it sort of in a simplified fashion. Why does disease develop? What's the biology? Who gets it? What's the epidemiology? How can you screen and diagnose? And then what can you do? What are outcomes? And what can you do with treatment to affect those outcomes? So when we look at the biology of colon cancer, we built a biobank. We have a database that goes with it. And we've done some analysis of mutations, epigenetics, chromosomal instability, and looking at the microbiome. And remember, I said our litmus test is there has to be some reasonable way why we think doing this research would affect a patient's outcome. And when we look at things like microsatellite instability, which is a rare population in the US, it's actually 5% in the US. In Nigeria, it's about 25 or 30%. And that drastically changes what your treatment options are. So a mutational difference in the Nigerian patients may explain why the Nigerian surgeons say, we give the same chemo you guys give to our colorectal cancer patients, and the response seems to be much less. There may actually be a reason why. Epidemiology, we built case control studies looking for modifiable risk factors. And I'm going to get into a bit about the screening and diagnosis work that we've done. Because that's where we've really focused a lot of our energy. So with ICEC, one of the primary questions he asked as an endoscopist is, can I identify a high-risk population that is worth screening? There's never going to be average risk screening for colon cancer in a country like Nigeria in the near future. So we looked at all patients over 45 years old with rectal bleeding for up to a week. And we did this at ICEC's hospital. That was the training cohort. And then we validated a risk model at 2 other centers, Aloran and Ibadan. And we found about 20% of the patients in all the centers, it was the same, had colon cancer. These were patients who have been bleeding on average for 6 months, had weight loss, change in stool. And so we built a risk model. So if you're going to scope anybody in a health system, we think we've now identified this highest risk population. But we were afraid we were just identifying stage 4 patients maybe a little earlier than we would have. But when we looked at the stages, a quarter of the patients were stage 4, as opposed to who we know presents on average, which is 64%. So a big stage migration with a small investment in a very high-risk patient group. This trial succeeded because it was generated by ICEC. It was an important question for them at these 3 centers. Based on Nigerian data, we powered this off of the endoscopy data from Nigeria. We also combined capacity building and research and patient care all in one with the trial. There were some refurbished colonoscopes, so some sites were able to build up their endoscopy techniques. And there was advocacy and patient awareness about rectal bleeding and that it was an important symptom to work up. At the same time, we applied for a UH3 NIH grant, and this is a combined academic industry grant, and we got this combined with University of Alberta in Edmonton, and it's looking at a colorectal cancer urine test. So they've built it on mass spec, but with this grant, we're building a handheld device where a couple drops of urine will hopefully, this is if it works, will hopefully be able to determine if your risk is high enough that you should have a colonoscopy, because we're trying to really limit who even gets a colonoscopy. So this is research in progress. So I'll talk a bit about the administration and infrastructure. It started at OAU and with MSK, and we really focused on small projects to get some early successes and to blunt our failures. We expanded into 3 centers, then 5 centers, and now we just expanded to 10 centers, and we've done this over about a 5-year period. One of the keys is ICEC leadership. There's also a physician leader at each other institution. We have 6 research assistants, a driver, a vehicle with cold storage, 2 -80 freezers, and everything's done in a REDCap database, and it's tablet-based. At MSK, our infrastructure is a half-time research assistant, administrative assistants. We've got about 20 active team members, faculty members, and all of them are twinned with Nigerian counterparts in whatever their field is. We've now outgrown myself and ICEC, and that's one of our major problems. While we're happy to have a growing program, we're both busy clinical surgeons. So next week, hopefully, we'll be posting a coordinator position. So if anybody knows of anyone good, let me know. And we're doing the same in Nigeria to also have a twinned coordinator between the 2 sites. Funding, obviously, is a major issue here. So we have NIH funding. We've got the pilot grant and the UG3 grant. We actually have a Fulbright scholar right now who is spending 9 months doing research with us in Nigeria. And we have an R21 and R01s that are all pending right now. There's some internal funds from Sloan Kettering, and we've had philanthropy from several foundations. Surgeons Overseas is an NGO that I started with another surgeon in about 2006, and we've been able to get funds that patients donate to help support this as well. We've really tried to focus on trainees and junior faculty. So the suit of our fellowship is a 3-month observership funded through Sloan Kettering to bring LMIC investigators over to Sloan for 3 months, fully funded. And I cut out all the non-Nigerians. These are all of our Nigerian colleagues, so it's about 15 at this point who have come and spent 3-month observerships with us. It was very surgery-focused in the front end, and now we've expanded to radiology, pathology, and anesthesia. And this has allowed us to really help build a cadre of junior investigators and junior faculty with a bit of a focus on cancer within their general practice. And then they've become our collaborators back in Nigeria. Lekan Olisahinde is a superstar from Southwest Nigeria. He got a master's in clinical research at Cornell that we sponsored him in, where almost all the master's time is spent back home doing your projects with online work. Lekan did a trial, for instance, during his master's. Can you discharge patients early after mastectomy? Traditional practice there is everyone has a mastectomy, everyone has drains, you stay in the hospital till your drains can come out at about day 12. He said, why not send them home on day 2 or 3? Developed an early discharge program and was able to prove that the seroma, surgical site infection rate, all these things were the same, and quality of life, as expected, was much improved to be out of the hospital and not in the hospital. We also provide 2 pilot grants a year. Laude Agundaran is a surgeon from Ilorin. This was his pilot grant on finding the causes of continuing late presentation of breast cancer. We do 2 of these per year, and we have them present at our annual symposium. And then we also are looking for a mechanism to help train people interested from North America in making this a part of their career. So we started a Global Cancer Disparity Fellowship. It's a 1-year fellowship for a board-eligible or certified surgeon from North America. They spend 3 months clinically with us at MSK, 3 months research at MSK, and then 6 months in Nigeria with ICEC and our colleagues in both clinical surgery and also doing research programs. Our first fellow, Greg Knapp, is currently in Nigeria now. So lots of obstacles throughout all this, data management obstacles, lots of lost data. REDCap has definitely helped us with that. QA remains a problem that we still are trying to work on. We are fairly involved with the Ministry of Health at this point, but the turnover level in the Ministry of Health is a real obstacle that we have struggled to overcome. Even things like transferring money for research. The Nigerian system now requires everything going through a centralized bank, so sometimes it takes 6 months, and sometimes it's lost for even longer than that. So that we've struggled with. and personnel management. That's why we need coordinators, because ICEC and I have reached the end of what we can do. So I'll finish with our themes for success. I think a lot of this is really based on personal relationships with clear goals, long-term commitment, and good communication. I actually see ICEC much more frequently than I see my basic science partners at Sloan Kettering who are across 68th Street, which is probably says a lot about my relationship with ICEC, but also my relationship with my basic science collaborators at my hospital. And I think it's important combining research training and clinical care with these meaningful clinical questions. So this is the whole group at Sloan Kettering, and this is all the leadership group at all the centers that initially were part of founding ARGO. Thank you very much.
All right, thank you, Peter. I'll next invite Dr. Ndlovu back to the stage here to talk about some of her experiences in Zimbabwe and beyond.
Here's my presentation. Thank you. Good afternoon. I think my job will be very easy because my slides, all the things have already been said. And, but I'm hoping that what I'm going to do is I'll just emphasize on those things that pertain to my personal experience and more skewed towards the radiation oncology side of things. And also, what I would like to highlight here is that I would like to highlight issues to do with clinical research partnerships in terms of the impact towards patient care. So when we're looking at the impact of research in terms of patient care, we're looking at it, my experience has been that of actually the impact starting even at protocol development. So when you are, this is the short term, then there is the mid-term and then the long-term benefits towards patient care. So the immediate term, during protocol development, just by having that research question and then saying, how are we going to go about doing this thing? A lot of things arise that actually immediately can impact on patient care. For instance, it could just be, how are we going to, the technique. What technique, how are we going to define the technique of radiotherapy, chemotherapy for this population of patients as we are right now? And therefore, you benchmark against a certain standard, which immediately makes you look back, and now you want to see what your daily practice is like compared to that standard that you're setting up for the clinical trial. And if you for us in the developing world, if you fall short of that standard, you already begin to question yourself. And it may then impact on what you're going to do for all your patients that you manage on a daily basis. And then and then now is the measure as well of how we're going to measure what we're doing. In a country like this one, the use of CTCAE for measuring your toxicity, the use of RECIST criteria for measuring your tumor response is probably, it may sound, okay, this is routine, but it doesn't happen in low to middle income countries. And you may have, even in one unit, several oncologists, each one doing their own thing. So when now you're doing it in a clinical trial, it actually makes you think. And then now when you're going back and doing things, you may now start to think about doing things more uniformly. The examples are many, but these sound mundane and but they are very pertinent, and they are very important in improvements that can happen.
Goodbye.
I like that one. So basically, then in the intermediate term, you're talking about, your patient, these are just simple examples that I'm giving. Patient follow-up. Suddenly you're looking at it and saying, okay, these patients, we usually just see them once and then we say goodbye, yeah, and we never see them again. But in the trial, you have to have some kind of scheme that you're going to follow. And then you start questioning again to say, is that the case? And then, of course, then in the long term, looking at long-term outcomes, that will now have a more long-term impact on what you actually do and the results that you get from the treatments that you're giving to your patients. So, and all this comes to evidence-based practice in low and middle-income countries. Do we really have it? And we have a lot of hindrances towards actually that, which is what research contributes towards. So we have the things that have been said previously. We have a variety of hindrances, such as human resources are scarce, the availability of infrastructure and equipment. And when you're talking about radiotherapy and chemotherapy, you're talking about the safe practices. When you're talking about the infrastructure, what sort of equipment do you really have? Can Center A and Center B say they're doing exactly the same thing? I think last night we had a nice chat of the use of, or the promotion of the use of cobalt in low to middle income countries, and saying, how evidence-based is it? I think this is something that we all have to think about it, to say, if we say it's all right, we can continue to use cobalt teletherapy in developing countries. How evidence-based are we? Especially, yes, it can be good for certain things, but for deep-seated tumors, right now, other institutions are saying for all pelvic tumors, you don't even use 6 MeV, you don't even use 6 MV, you are using 10 MV and above, and cobalt is an equivalent of 1.2. What evidence is there to say, yes, we can carry on and still get the same quality of treatment and the same outcomes? So those are some of the things that we need. And then the financial resources, of course, and basically the sum total of it is that there is a paucity of clinical research to generate local evidence in Africa in particular, but I think probably in all ICs it's the same situation. So why then do we need the clinical research partnerships? This is by no means exhaustive, but these are the things that I thought we've seen applying to us, that we can address common areas of interest, and then of course the transfer of knowledge and skills has already been covered by the previous speakers, and the targeting of young investigators who have got local mentorship. In our situation, we have cancer research was not really confined to our cancer unit. There's a lot of cancer research that's been going on over the years, but it had been done by other departments such as surgery, gynecology, internal medicine. And we are now, as a cancer unit, we are relatively young compared to these other specialties. So we are now taking up this task of actually setting up collaborative partnerships. And one or two of the collaborative partnerships have been with IAA, with the AMC, and we actually now have found that our young investigators, we have co-opted them into the studies that have happened, and we actually have 2 fellows that are actually having fellowships with the AMC and are doing some studies there relating to HPV in cervical cancer, in penile cancer and in vulval cancer. Another way that research partnerships can actually be of benefit is to facilitate accruing sufficient number of subjects so that we can satisfy the objectives of our trials within a reasonable frame of time. If one partner does not see this cancer often and the other does, that would be very ideal. And then, of course, the provision of a wider range of clinical judgments concerning the value of that intervention. For instance, if we're talking about the use of cobalt teletherapy, which I've alluded to, certainly it would be good to have perhaps maybe more than one center that could actually address that and see, because then that would actually be more robust evidence than having a narrower range of clinical judgments, and also being in different geographical positions will even strengthen that further. So that will also lead to the opportunity of good subsequent generalization of trial findings. And if this is done in partnership rather than done elsewhere, and then that evidence being then utilized in another geographic situation, it would be better. And we would be absolutely confident that we are using local evidence to manage our patients. So I just thought I would cover a few key points on clinical research in our kind of situation, and I gave a few advantages and a few disadvantages. So one of the clear advantages is the abundance of research material. Our centers may be small, but they usually have got a wide catchment area. So we have no shortage of patients, and we have no shortage of conditions because the disease burden is high. And there may be some unique research opportunities, such as, in areas of HIV and cancer and other cancers that are probably seen in our region more than in other regions. And because of that abundance of research material, there would be shorter accrual times, and we tend to have younger departments with younger people who are actually keen to take up research. That I can say for our center, because we have a training program, and part of the training program is actually that it involves research. So there's always younger people who are keen to actually engage in research. Then some of the disadvantages have already been mentioned, like no protected time, language barriers. The language barrier, by the way, is both, is many ways, shall we say. So there are many languages in Africa. So within a country, you'll find that when it comes to things like informed consent, how do you translate it? To which language do you translate it to? How many languages are you going to consider as actually being sufficient to cover that particular population? And then in that translation also, so when you have collaborative partnerships, you may, or in a multi-center clinical trial, you have this model consent, which is in English. And you may not even find the words to translate it and keep the meaning the same to another language. So there are all those issues that come in. And then if it's say maybe a questionnaire that is being administered to a patient, again, the same language barriers come in. So fortunately for us, English is our national, one of our national languages is the media of instruction, and probably more than 90% of people in our country do speak English, and they will take English consent, but still we have other languages and we still feel it. Distances traveled, patients come from far, and that can impact actually the conduct of the study, particularly in terms of the follow-up of patients. And the limited know-how has also been mentioned here. I will actually want to highlight one thing pertaining to radiotherapy in the sense that when we're doing one multi-center clinical trial on the feasibility of chemoradiation for cancer of the cervix in HIV-positive women, one of the reasons why we couldn't we ended up doing it as 2 centers when we had set up to do it as 5 centers, simply because of the QA that is involved. So when we're talking about radiotherapy, the monitoring of QA, just to have the center registered. In some centers, they didn't have enough of the physics, medical physics know-how, and things like that, and even the RTTs, or what do you call them, the radiation technician, to have them to actually do things like GCP, and it became very difficult. So it's not like they couldn't do everyday clinical work, but now when it is called upon them to do much more than that, there were issues that came up. So specifically for multi-center clinical trials in Africa, one of the very interesting things that I would like us to dwell on is the standard of care issues. Again, it's a very basic issue, but it has got a lot of bearing, because if research partnerships are going to be built with in a low income setting, it has to be borne in mind that what is supposedly standard of care in America is not standard of care elsewhere. And in fact, what is standard of care? Does it even exist? That's the question, because we could have guidelines, we could have knowledge of what really has to be done, but the resources on the ground and all the other factors that have already been mentioned can actually have an impact on what is actually done. So yes, we know that, when a woman with CA cervix comes in and they are bleeding, we have to, do a CBC. But is it available? How often is it available? When do you repeat? So all those things come in, and actually the actual drugs that are to be used, they could be there in the guideline, but are they always available? What proportion of patients get it? So at the end of the day, that standard of care has to be defined prior to actually, and perhaps even supported by the trial for the trial to take place. And so that also touches really on the diversity that we found in institutions, the resources that we find in institutions, and actually the availability. When we're talking about radiotherapy, Africa, 54 countries at the last count, but at least more than half, slightly over half of them, no radiotherapy facility. So how do you then, they may have the correct patient that you would like to study, and they may be very keen to join the multi-center clinical trials, but they may not have those resources available. And again, the variation of clinical guidelines I've already touched on. Will the NCCN harmonized guidelines for sub-Saharan Africa bridge that gap? We do not know. I think that's my last. So who sets the agenda? I think it's already been covered. The varying priorities, too many priority areas, mismatch of priorities with what can realistically be done, and should currently acceptable global standard be used, or what is deemed appropriate for the setting. Sometimes there may be the temptation to tweak things down a bit and say, okay, because things are not done up to this standard, maybe we can set our trial to slightly below standard, which may not be actually an appropriate thing to do. And all these things may affect the internal and external validity of what we're doing. So in conclusion, I say there is need to promote evidence-based practice in Africa, and generation of local evidence should be promoted. Clinical research partnerships are key, and this in this end to promote skills development for young investigators in particular, leading to quality research. And local priorities for research must be taken into account. And before embarking on studies, local constraints have to be well understood and feasibility determined. And that's a view, one of the views of the Victoria Falls from the Zimbabwean side. And I must emphasize that the Victoria Falls is 1.5 kilometers long from the Zimbabwean side. So this is just a perspective of it. You know, it's just like collaborative research, you know, many perspectives, but the whole sum total of the experience is absolutely mind-blowing. Thank you.